It's a little ironic because it's mostly from actually Caucasian folks. So, but you have a few expats that may have this. I don't have any financial conflicts. I just want to thank my partners, Dr. Sikidis, Dr. Herzig, and Dr. Barton, who's at another hospital, for generously sharing their slide. So we're going to talk about inflammatory bowel disease and how we as surgeons approach them. We'll discuss ulcerative colitis first, and then for Crohn's disease, we'll discuss abdominal surgery and then anal surgery. So we think that inflammatory bowel disease is an autoimmune disease. There's actually genes that have been found to increase your predisposition to ulcerative colitis or Crohn's disease. And ulcerative colitis is actually a very attractive disease for surgeons because if the problem is the colon and you cut out the colon, there's no problem, right? Well, the problem is that ulcerative colitis also has extra intestinal manifestations or other similarly associated diseases that you'd get with ulcerative colitis, like arthritis, or you're hypercoagulable and more likely to develop blood clots, like a deep venous thrombosis or a pulmonary embolism. Erythema nodosum is where you get these big, red, hard, tender nodules below your knee, and pyoderma gangrenosum is typically an ulcerative disease that's around ostomies. These actually get better if you actually remove the colon, whereas primary sclerosing cholangitis will not. And it actually is it was a way we sometimes diagnose these patients. They have primary sclerosing cholangitis, liver failure, and then they get to a liver transplant, and then later on they develop bloody diarrhea, and then we get called. So if you have ulcerative colitis, there's up to a 1 in 4 chance in your life that you may have to have your colon removed. And you have a higher risk of having your colon removed if you're young, if you have the extra intestinal manifestations, or if you've had inflammation of the entire colon. So there are 2 ways that we would operate on these patients. There's the urgent, where they have a problem, like fulminant colitis, where it comes on all of a sudden, toxic megacolon, where they had a hemodynamic instability with a very large, fragile colon that could perforate or perforation. And elective is something we see less often, but typically is when they've had multiple biologics and they're not getting better, with the invisible dysplasia on chromondoscopy, that we get nervous about removing the colon to prevent them from having cancer. So let's talk about urgent surgery. So toxic megacolon. Toxic means they have some sort of vital sign change, like fever, tachycardia, hypotension. Megacolon just means a big colon. When you have on a supine abdominal X-ray, if it's really large, then we get a little bit nervous, and then we clinically follow them. So if they have persistent diarrhea, persistent bleeding, increasing narcotic requirements, then we worry about having to take out the colon. And the bottom picture is a beautiful picture of a not so beautiful colon after we remove it. It's actually quite lovely. You can put it around your neck, keeps your neck warm for at least 15 minutes before pathology picks it up. So perforation, you can see on this upright X-ray underneath the right diaphragm, there's a lot of error. And it's surprising how the abdominal exam will not be reflected. The abdominal exam will not reflect the perforation because a lot of these patients are on high dose steroids. So they could be smiling at you, talking to you, asking to go home. You get this X-ray and you see all this free air, and then you decide we need to operate on them. And if they perforate, they have a higher mortality, 20% versus like 4%. So typically, people with fulminant colitis, they have severe abdominal pain, distension, bloody diarrhea, or just rectal bleeding, and we typically get admitted to a medicine service. Our GI colleagues are really helpful, and they come and recommend different treatments. And if they don't improve, typically anywhere between 3 to 7 or 5 to 10 days, we'll offer them a surgery. So in the US, it's really easy. There's only 2 options. There's a 3 operation package or a 2 operation package. There's like basically 3,000 baht package, and there's the cheaper 2,000 baht package. So let's talk about the 3,000 baht package. So the first one is where they're sick. They are malnourished, they're hypotensive, they're on steroids, they're on biologic therapy like Remicade, Entyvio, Skyrizi. These are the patients that we actually just removed their, if I can get this right here, their colon. So from the ileocecal valve all the way to the top of the rectum. and we bring the small bowel up to the abdominal wall to make an ileostomy, and we just staple off the top of the rectum. So by removing about 90% of the surface area involved with disease, we remove a lot of the risk for perforation, and they tend to feel better pretty quickly. The second stage is where we think that ulcerative colitis always involves the rectum, and it involves the nearby colon. It's confluent. So it's either colon and sigmoid or colon, sigmoid, and descending. It's always confluent from the rectum all the way up. So we need to remove the rectum to completely eradicate the problem. So the problem is if you remove the rectum, then how are you going to be able to poop out of your bottom, right? The rectum is like a really nice purse they could buy at the night bazaar in Chiang Mai, right? It looks lovely. It's small when you don't need it. You can fill it up with lots of souvenirs. It'll get bigger. So we need to make something that can expand and get smaller. So what we do is we take the small bowel, we fold it back on itself to double the circumference. And then we sew it, or in this case, we actually staple it with a really expensive stapler to the anus. So then they have a neorectum or new rectum. So now that we removed the colon rectum, this is a pretty technically difficult procedure, and it has risk of falling apart. So we actually take the bowel above the pouch, and we have the stool go somewhere else while it has a chance to heal. So the second operation is proctectomy. We remove the rectum. Ileo-J pouch is the purse that we're making. We're stapling it to the anus, and we're making the ileostomy above to let it bypass it so it has a chance to heal. The third, the last 1,000 of the 3,000 baht surgery is actually it's a lot more. It's probably like 300,000 baht in the U.S. because we really charge a lot of money. But anyway, the last stage is actually getting rid of the ileostomy, which patients are really excited about. And before we could do that, we typically do a contrast study that goes through the ostomy over here, and then it trickles down to the pouch, and you want to make sure that there's no leakage at the connection. And then you can see over there is just a tiny scar a few months later. So an elective situation is where they're not sick. They're not malnourished. They're actually doing fine. It's just that, for example, when your GI colleagues do surveillance and they do biopsies of normal looking mucosa and they come back as low grade or high grade dysplasia, we get nervous that they're going to have cancer that we can't see. Dysplasia in ulcerative colitis tends to be flat, can look normal under normal endoscopic exam. There are ways to find it by using the chromoendoscopy, which takes a long time and involves a lot of methylene blue. There are newer scopes that use high definition that help you look at the patterns, so you don't have to use chromoendoscopy, and that's a lot faster. That technology is actually evolving over time. Then the other one would be intolerance of a biologic. So they're managed in terms of no abdominal pain, not having diarrhea, but they just can't tolerate the side effects, so they would come to us. In this case, because they're not sick. The other thing is the reason why we do is we survey for dysplasias after 8 to 10 years, especially a pancolitis. They have a risk for of developing cancer. So they get frequent colonoscopies and biopsies, and they get to us when the biopsies are concerning. So in elective case, we get the two-stage operation, the 2,000 baht operation. So instead of removing the colon, operation 1, rectum, operation 2, and then getting rid of ileostomy, operation 3, we remove everything in the first operation. This is the whole package, right? You get the mountain cottage, you get the city hotel, and then you get the beach stay, all in one time. So remove the colon, remove the rectum, make your purse, you stick it to the anus, and then you divert them. That's operation 1. And operation 2 is getting rid of the ileostomy. Patients actually really like that because it's fewer operations. We typically separate our operations by 3 months. So within a little over 3 months, they could be completely done with their operation. So stage 1 again is removing colon, rectum, everything. Then you make your new rectum. You take the small bowel, fold it back on itself, and then you staple it to the anus, and then you get a temporary ostomy upstream. And then you get your study to make sure there's no leakage, and then you get rid of the ileostomy. And then Those are the two most common operations. Now, some of our patients actually have preoperative incontinence. So if they're incontinent before the surgery, they're not going to be more continent after the surgery. So if they're going to be pooping in their pants, in this case, we just remove the colon and rectum and give them an ileostomy. That'd be permanent. But the thing is, patients that have their colon out in a permanent ostomy actually have a pretty good lifestyle or quality of life, that is, based on studies. Okay, so we're doing more 3-stage operations because more of our patients are on biologics. So there are two things we've noticed about biologics. One is with biologics, patients are getting better medical care, so they're needing less colectomy and pouch. So we do less pouches now than we did before, and which is something that we've noticed. I train colorectal fellows to become colorectal surgeons, and we've noticed that it's getting harder and harder to get the pouches to treat our fellows because there are fewer pouches needed. The second thing is that with biologics, there is a trend, but not definite proof that there's a chance that the pouches could fall apart after we construct them. So most surgeons require you to stop the biologic for a period of time, typically one dosing interval, and then we'll do the proctectomy and pouch. It's interesting that there was 2 meta-analyses published in the same year that looked at the same 4 studies, and they came into completely opposite conclusions. One was by a surgeon that says you can never use a biologic before a pouch. The other one was from a gastroenterologist that says you can always use biologics before a pouch. So it's there's a folksy author from the U.S. who had a fake name called Mark Twain, and he said there's 3 kinds of lies. Like where there's 3 seasons in Bangkok, right? There's hot, very hot, and as Jenny said, damn hot. So there are lies, there are damn lies, and there's statistics. And basically, 2 different people looked at the same data and came to opposite conclusions. So this is actually a big point of contention where it's still controversial about whether or not you stop biologics, but most surgeons, understanding that if the pouch fails, it'll likely have a permanent ostomy, will stop a biologic beforehand. Typically, any other operation where we do for inflammatory bowel disease, whether it's ulcerative colitis or Crohn's, it's actually okay to continue the biologic. So people get freaked out about when should I stop it? And the answer is typically you don't have to, unless it's a proctectomy pouch. So this is the point where I was saying that, for an urgent operation, if it's an emergency, you just have to have an operation. You don't care about stopping the medication. You just do what you need to do. Electively, with the exception of a pouch, you can pretty much do it. You can do everything. So life with the pouch. So the pouch that we make is not as good as the rectum you were born with. It's like the fake purse in New York City, South Side, is not the same as a really pretty Louis Vuitton one you got from Nordstrom. So the problems are you can have, after the operation, you can have bowel obstruction from adhesions. The pouch can leak at the connection, which is actually pretty low, but it can be a problem. The connection can become narrowed and make you constipated, and you poop more often. So if a normal person would poop 1 to 3 times a day, normal function for a pouch is between 4 to 8 times a day. So you're more likely to get dehydrated. There's something called pouchitis. Pouchitis it feels like an ulcerative colitis flare where you have low-grade fever, abdominal pain, crampy abdominal pain, increased bowel movements, bloody bowel movements. It's almost like a UC flare, but you don't have any colon to flare. This happens about 50% of the time, at least for once, in patients with ulcerative colitis. It only happens about 1% of the time in people with familial adenomatous polyposis, which is a totally different disease, but you do have the same operation. And we think it has to do with the microbiome of the pouch. Small bowel isn't used to having stasis of bacteria, whereas a rectum is. So we typically treat with antibiotics. And the understanding of pouchitis is changing because there are some gastroenterologists for chronic pouchitis who give them mesalamine or even give them biologics. So typically they poop 5 sometimes a day, maybe once at night. Daytime continence is perfect. Nighttime continence, they may have some smearing. So most people have a pretty good quality of life after a colectomy, whether or not they're actually put back together again. So this is a simplistic algorithm where basically patient who's sick, malnourished, on steroids or biologics, they get a 3-stage operation. So colon operation 1, rectum operation 2. When you make your new rectum, it's rectum's like a placeholder. As soon as you take out the rectum, you have to put a new one in, and then you get rid of the ileostomy. Versus the other one would be more like people having low or high grade dysplasia that's invisible on endoscopy that you can't just follow. Those, you remove the whole colon rectum, lower your risk for cancer, make your pouch, operation 1. That's the whole thing's one operation. And then number 2, you could get rid of the ileostomy. And it's surgeon preference, but increasingly we're using a minimally invasive approach to removing the colon rectum, which can be laparoscopic or robotic depending on your training or how rich your hospital is. So, okay, so Crohn's disease. Crohn's disease, again, is an autoimmune disease of the bowel. But in this case, instead of just affecting the colon rectum, it can affect anywhere between your mouth to your anus. Typically seen in Northern Europeans, like actually Russians, and the Ashkenazi Jewish population, which I would have said before visiting here, there are no people here, but apparently you have a big expatriation population that you may see these patients. Typically, it's bimodal distribution. They could present when they're young, so in their 20s. I haven't been in my 20s for several decades, and then 60 to 80 years old. So what happens? Basically, it's a severe autoimmune disease against anywhere between the mouth and the anus. The most common place is typically around the ileum or the cecum. Another more common place is just small bowel, and the next most common place is colon. And then here's another picture where the small bowel that's most involved is typically the terminal ileum, and then next would be ileocolic or ileocecal, and then colon, and then perianal. And perianal disease is about a third, so that's actually we'll briefly touch on that later. So we classify Crohn's disease as either fistulizing. Technically, the terminology is penetrating, where basically the inflammation goes all the way to the bowel, and then it leads to leakage of stool, and that comes out to the vagina or the bladder or the abdominal wall, which makes people super unhappy. Stricturing or stenosing is when the bowel actually becomes narrowed and can lead to obstructive symptoms. And inflammatory just means that it's swollen, but it's not obstructed and it's not perforated. So there's something called CT enterography. It's basically more expensive CT. It's a fancy CT that actually gets several IV contrast, oral contrast, but the oral contrast is what we call negative contrast, meaning that the contrast is actually dark, so it allows you to look at the mucosa a little bit better. And there's various signs that you can look at. You can look at fat stranding. The nice thing about CT is that inflammation leads to extravasation of plasma into the extravascular space, which makes it look hazy. So like for Art, if he had a CAT scan, you would see nothing because he has no fat. Whereas me, I'm a big ball of fat. So if I were inflamed, you'd see lots of haziness. So I'm a great person to examine for Crohn's, and he would be harder. So if the fat strain is pretty easy to see in CT, especially in the US where we're all fat. So except for Cicadas and Bruda. So mural sign is where this thickening of the circumferential wall, and you can actually see it looks like a target, like an arrow that you can shoot at. And then the comb sign is where the inflammation leads to mesenteric dilation. Dilation of the mesenteric arteries and vessels, so it looks like a comb. In case these are just suggestive of which segment of the bowel is actually inflamed. The fistula is a connection between two things that should not be connected. Okay, so MR enterography is just a more expensive version of this. It's actually advantageous for our young patients who get repeated imaging because they have less radiation exposure. The problem is it's expensive, and it takes a lot longer to accumulate the images. It's typically harder for the surgeons to interpret because we're typically used to reading CT scans. But basically, the T1, you can see take up of IV contrast wherever there's inflammation, and you can see a little bit of edema on T2. So we can push on. So the difference between the two is that CT is super fast and it's cheaper. So it's like McDonald's, and it's good looking at active inflammation, and we're used to reading it. MRI is really nice because there's no radiation, but in the US it's really hard to get because it's really expensive. It's a dynamic study. It's good at actually differentiating between inflammation, which will respond to anti-inflammatory medications, and then like fibrosis, which is going to require some sort of resection or some sort of surgical modification. So anyway, so typically a good answer for any reason to operate is failure of medical management. So if they have no more options, or they're not improving on medical therapy, or they're obstructed from a stenosis, or they're a fistula from a perforation, then we typically will operate. So a couple things are, for patients with Crohn's disease, the only reason for a patient to have short gut is they have a super exuberant, excited surgeon, right? If they cut out too much bowel and keep on cutting out too much bowel, you're eventually going to run out of bowel. Okay, so the goal is to only cut out the affected bowel with as minimal margins as possible. So the Cleveland Clinic, they actually did a study where we used to believe like we had to get negative margins for Crohn's disease, otherwise it's going to come back. So we used to take 10 more centimeters on each side of the normal bowel, and they'd end up having short gut. So they had a study where they randomized between 2 to 10 centimeter, 12 centimeter margins. There were no difference in terms of recurrence. So we just minimized the amount of bowel resected. And then, but there are other options besides resecting, right? When you resect it, you can put it back together again. And then there's controversy on how do you put it back together again. And we'll talk about that in a little bit. The strictureplasty, which is basically when you cut the stricture down the middle and make it fatter. And then you can bypass it. It's like traffic in Bangkok. When it's really bad, you get off the next exit and find another way around. Okay. So strictureplasty. Strictureplasty is typically when you have multiple areas of narrowing, and rather than cutting out all that bowel, we'll just basically make those areas instead of skinny fat. Okay. And then that helps us avoid, especially if they have multiple surgeries, cut out multiple amounts of small bowel. So when can we not do strictureplasty? So if the stricture or the area that's narrowed is inflamed, if you cut the inflamed area open, try to sew inflamed tissue to inflamed tissue, it will not work. Typically, if there are multiple areas of strictures like right next to each other, it's more efficient to just cut them all out. And also, it's malnutrition. So you need the same amount of nutrition to heal a strictureplasty as you do for a bowel anastomosis. So here's some pretty pictures or cartoons, okay? Cartoons of a stricture. So the stricture is like right here. So you just cut it along the antimesenteric border until you open it like a centimeter or 2 on each side. And then you put a stitch here and you put a stitch here and you pull it in this direction. So this skinny area becomes fatter, and then you sew it in 2 layers. So it's like, this is Art's body, Professor Art, and this is my body. So little head, my brain smaller, big tummy, skinny legs, okay? So that is a strictureplasty. Typically, this technique is used for a shorter one that's 5 to 10 centimeters long. And then there's a finny, right? There's the bigger stricture, which is like 10 to 20 centimeters, where you can actually still cut down the antimesenteric side of the bowel. So you completely open it up, and then you fold it in half right here. And then you sew the middle, this side to this side. So that's a back wall. And you sew this side to this side, that's front wall. And this creates a kind of a big chamber, but at least it's a big opening for this to go in and then back out. That's a finny. That's actually pretty uncommon. We actually don't do that. Most of the strictures are actually pretty small. And in fact, if they're really small, I've seen gastroenterologists successfully dilate them multiple times until they can't dilate anymore, and then they call me. This is published by a famous Greek doctor, I think, surgeon, Dr. Michalasi. So he's a lovely surgeon who figured out a way to deal with long strictures. Long strictures are like 20, 30, 40 centimeters. So again, you actually cut it down the antimesenteric side the whole way, and then you cut it in half. You actually have to trim off like the edges so it's more like a cone on each side, and then you sew this this to this, and you get this back wall. You sew that to that, and then you get the front wall, and that's the what we call an isoperistaltic, because basically stool would go this way, it goes this way, so it goes in the same direction. It's actually easier for them to scope if they were doing enteroscopy, and it's a nice wide open stricture. Okay. The reason why we don't do strictures as often is because medical management has gotten so much better that a lot of times we only do 1 or 2 resections, in which case it's more efficient just to cut it out and do an anastomosis. So strictureplasty, this is all the detail about the study, but basically the restriction rate is low at 4 years, and the complication rate is pretty low. And again, when Dr. Sikidis and I were training, they required us to do 2 strictureplasties to graduate. But since the average training program offered 0.9 strictureplasties per fellow, they figured, well, we can't fail 95% of the programs because they can't do strictureplasties for a disease that's disappearing because of the excellence of our GI colleagues. So this is another one that says they have a low risk rate of recurrence, and yet another one saying, so this is the controversy that's currently brewing. It was brewing on Twitter, but now it's called X. But basically, there's something called the Kono S anastomosis. So Kono is actually named after a Japanese surgeon. His name is Dr. Toru Kono, who pioneered this anastomosis. And he actually passed away in 2021, which is really unfortunate. But basically, the theory was that most of the problems for recurrence are due to mesenteric inflammation. And if the anastomosis is close to the mesentery, you're more likely to have compromise of the anastomosis than when you have a recurrence. So he decided, well, what if you did your anastomosis on the opposite side of the bowel, so it's as far away from the mesentery as possible? Could it lower the risk for recurrence? And he's actually been doing it since 2003. It's been done in Japan for a longer time, and then I think 2011 in the US, where people were starting to adopt his technique. Just like when one of the Minnesota attendees came over to Thailand and learned about the lift procedure, the ligation of the intersphincteric fistula tract, and then brought it back to the States, it became the rage, a popular way of thinking the fistula. I think Dr. Goldstein came and brought this back. Anyway, the idea is, so you do your bowel resection. So you cut out the area of either fistula or stricture, and then what do you do with the 2 ends? So typically, in the past, we would just do like a Barcelona type, staple anastomosis side to side. But instead of doing that, he's actually doing it hand sewn. So what he does is he takes these 2 staple lines and he sews this bowel to this bowel. So now there's actually 2 blind ends stuck together. And on each side of this, there's a 7-centimeter anti-mesenteric longitudinal incision. That's a centimeter away from the edge. And then you sew this to this and this to that. So it becomes Dr. Art's body to my body, skinny to fat. Here's another cartoon. Now, this is actually from the chapter I uploaded for you. Dr. Barton actually wrote a chapter when he was at LSU on the Kono S anastomosis. So I think Jenny has it if you want to be able to download it. But this is another cartoon where you do your resection, you sew the 2 ends together, then you make your incisions, you put sutures to pull them wider, and then you sew this side to this side and this side to that side, and it becomes a connection that's on the anti-mesenteric side of the bowel away from where you think it's going to recur, which is the mesentery. So there was a trial called the Supreme-CD trial, which is a trial. It's a single institution trial done in Naples, Italy, where it was a single institution randomized prospective trial of like 78 patients, where they randomized to the Kono S anastomosis to the standard. And initially, the short-term results showed a mild decrease in recurrence at 6 months after the Kono S compared to conventional. But it was a small single institutional study, so it was not enough to change care. So they actually reported this year at DDW their long-term results. So at 3-year follow-up, the chance of a patient needing surgery after a colon-less anastomosis was 0%. And the chance of having a repeat operation after a standard operation is 8.8%. So higher, so significantly higher. To put this in perspective, older data, which I'll show in a couple of slides, is that after an operation, typically we quote a 25% need for an operation at 5 years. So part of it is since 2018, medical therapy has improved, so we need to operate less. But two is that this might actually be something we may become standard in the future. Most surgeons are very resistant because it takes a 5-minute operation. It makes it a 45-minute operation for each connection. So it takes longer to hand sew. But if it means that you don't have to operate on it again, it might be worth it. So anyway, that's a major controversy. On Twitter, people were voting on whether or not they didn't want it or didn't want to do it. And the majority of people said they didn't want to do it unless there's more data. Okay, so that's small bowel disease. Ileocolic disease is actually a far more common version where it's a terminal ileum and with or without the cecum. Typically, it presents with similarly like small bowel disease. And here's a picture of, okay, let's see if I can find okay. So this stuff on the right is small bowel, and this is cecum, and this stringy little thing is is the stricture. You can see it's a tiny channel between the small bowel and there, and that's stricturing ileocecal Crohn's. So that's our string sign. So there, okay. Okay, so anyway, if there's a problem with the ileum or the cecum, we're a surgeon, we just cut it out. No cecum, no problem. So we cut it out and then we just put them back together again. And you can actually put it back together with the colon-less approach if you want, but most of us just staple it because it's faster. Here's an example of the ugly specimen that we resected, and let's see if I can get my thing. So this area right here is the phlegmon around the stricture that is right here when we cut it open. You can see over here is regular wall. You can see how much thickened this wall is and how small this channel is. So this is a common operation we do. We typically do it laparoscopic. It can be done either open or robot too, but it's a pretty short, easy laparoscopic operation. We also have, in addition to small bowel disease, ileocecal disease, you got colonic disease, and it could act like ulcerative colitis and presents similar, where you have abdominal distension, abdominal pain, diarrhea. It could be bloody, and sometimes we can't tell. Sometimes we call it Crohn's, sometimes we call it ulcerative colitis. Sometimes we call it indeterminate colitis because we can't tell. So this is a picture where most of the colon is dilating over here. You can see it's narrow, and here's it's more narrow. So this is mostly the disease that's involved in this case. Since Crohn's can affect any amount of bowel in any location, we typically try not to cut too much out. So we typically talk about segmental resections focused at the area of involvement. So the easiest answer will be proctocolectomy and ileostomy. No colon, no rectum, no problem. But the thing is, you don't want to punish them for having a small area of colon involved, so we would typically do segmental colectomy. Sometimes you can just remove the colon and leave the rectum in place. And patients like that because ultimately you can actually get rid of their ostomy. So here's a picture where we do an abdominal colectomy, where you remove from here, to here, and then you sew a small bowel to the rectum. And patients like that actually has better function than a pouch because it's the rectum you were born with. We only do that if the rectum were not involved with Crohn's disease. So it's colonic involvement, but no Crohn's. So no rectal involvement. So you take normal rectum, normal small bowel, sew them together is like a match made in heaven, right? East meets west, perfect marriage, happiness. Okay, so this is an example of ugly colon that we took out before we connected their ileum to the rectum. You can see how red and hemorrhagic the stuff is on the left, which is actually the cecum. Okay, so Crohn's colitis, we know that you can just remove a bit of the colon. You don't have to remove the whole colon if you don't have to. And then this is data from 1986. So 1986 is a long time. Most of the nurses were not yet born. I was still in elementary school. Back then we said 25% at 5 years, 50% at 10 years, and 75% chance of an operation after the first operation at 15 years. But this is 1986. This is a long time. I mean, like Taylor Swift was not even born yet. I mean, it's a long, long time ago. Okay, so we think that the recurrence rates are a little bit less with the medical management, and we think that things that can increase recurrence is there's a known genetic component to IBD. We think it only comprises maybe 10 to 15% due to twin studies. Smoking increases risk for IBD. Penetrating disease or fistulizing disease, ileocecal disease. And we now are thinking that maybe the anastomosis might affect it. This is newer data that's come out over the last 2 to 3 years. But the thing is, people aren't convinced because this makes them take it so much longer. I'll give you an example. I almost had heat stroke when I was walking to a beautiful temple in Chiang Mai because I'm old and out of shape. That's the long route. I could have taken the van to drive all the way up to the temple, which would have been the shorter route. So the stapling is the shorter route, very comfortable. Okay, the longer route might be the better way to go because it was actually a beautiful hike once I stopped fainting. So anyway, so we'll see over the next 5 to 10 years if we get more studies to see whether the CONE-OS is actually really something that we're going to have to do. So I want to briefly discuss peritoneal Crohn's disease. Peritoneal Crohn's disease is very complicated because it's an autoimmune disease against intestinal lining, which means it's above the dentate line. It tends to be higher fistulas involving more anal sphincter. It tends to be multiple fistulas. It tends to be complex fistulas. It tends to be branching fistulas. And then it may or may not be associated with rectal inflammation, which makes everything worse. So this is a picture of a really bad rectum. If you have this rectum, you can pull me aside after the talk, and I'll be happy to help you for free. This is an example of peritoneal Crohn's where there's the obvious fistula up here, but then you can see next to it there's multiple other small holes. This is multiple fistulas, atypical for standard anal fistulas. And then this is like long-standing problems where it's really, really bad, and there's not a lot we can do at this point. So typically, the answer for anal Crohn's disease is a ceton. Placement of a string that goes to the fistula to prevent an abscess. Because if the external opening closes, but the internal opening is still open, stool can get in, and you get off an abscess. And the abscess never happens at 2 in the afternoon. For me, it always happens at 2 in the morning when I'm trying to fall asleep. So to avoid cutting the anal sphincter, we place cetons. Then we do a scope to see if there's rectal involvement. And if there's no rectal involvement, you can treat them like a regular patient who doesn't have Crohn's with standard treatments for fistulas. But if there's rectal inflammation, it's of active futility, and you can't do anything successfully until the medical management is optimized in the rectum. So the ceton is just a name for the string that goes through it. We don't use the fistula plug because Dr. Wexner actually published a report that the initial success rate for a plug, where it basically crams something into the fistula, was 85%. But when he actually studied it, it's only 15%. And the insurance company stopped paying for it because it's an expensive plug to stick in someone's butt. So here's a picture of the string that we place in. We didn't examine anesthesia because it hurts too much for them to do it. And unlike the Thai people, the US cannot tolerate pain. So you have to be unconscious for me to do this. Okay. Any questions? I'm happy.